Perhaps you're watching this video because you're wondering about posterior presentation. So as a doula, it's actually an incredibly important topic to be well aware of what is posterior presentation, what causes it, and how would you know, or how would you suspect that maybe what we've got happening here for this woman is a posterior presentation. So first up, posterior presentation means the angle of the baby entering into the pelvis. Maybe they haven't actually entered the pelvis terribly well, because posterior means the baby's backbone is around towards the mum's backbone, and it might be just partially, it could be fully, but either way, if the baby's around that way, it might not kind of fit terribly well, and the head might not be engaged very well. If the baby's anterior and the baby's backbone is around towards the front of mum, anterior, then the baby's head might engage quite nicely into the pelvis. So if she's got a lot of backache that's causing her to be very irritable, then there's your first little indicator that maybe this baby's in the posterior position. Now, the time that I would become a bit suspicious that a baby's posterior, the one that would really flare up for me, and let's just assume that this woman hasn't been checked today by a midwife, but she's notified me my membranes have just ruptured, so my waters have broken. It's been a great big obvious hot wet gush, and I've got no sign of labour, or very, very faint, hardly anything on the Richter scale of labour contractions. So if we had ruptured membranes and no contractions, there's a very good indicator that would certainly make me very suspicious. This could be posterior. And so in that case, my first reaction to the mum would be, it is a good idea to get checked out by a midwife. If we've got ruptured membranes and we've had good regular contractions, then it's not a concern. But if we've got ruptured membranes and no contractions, no good regular contract, then you would call up, and if it's the hospital, they'll say pop in, we'll check you out, we'll probably send you home, and then the midwife can have a feel and see if this baby's posterior as well. Some midwives are more than happy to tell you. Other midwives are like, oh God, no, I don't want to tell you, because I don't want to worry you, I don't want you to get upset, I don't want you to go into a full-blown panic attack going, oh my God, it's posterior. And some women will just drop the ball on it straight away, and they'll just give up and they'll panic and freak. Look, this is not a serious situation, and it certainly isn't any sort of a medical complication. See it as a minor little hiccup in the scheme of things, but there's a lot that we can do to help this woman. Number one is encourage her to lean forward, even just a little bit. If we've got the shoulders in front of the hips, that helps the baby to rotate around. Why? Because the back of the shoulders and the back of the head of the baby are actually the heaviest part, and gravity will help bring the baby around into an anterior position. And so it's important to know that just simple posture measures, sitting on the birth ball, feet apart, knees apart, leaning forward a little bit. She doesn't have to be squashing her belly or leaning forward a long way, just a little bit will be enough that gravity will begin to bring that baby around. Sometimes babies swing around in one big go. That actually happened for a client of mine once. We were in Sutherland Hospital. She was in the bath. She had her knees spread wide. I had a pillow on the edge of the bath. She had her arms on the edge of the bath and leaning way forward. And she was being quite vocal. Anyway, she was whinging a lot about her backache. And then all of a sudden she went, oh, like that. And I could see the belly change shape. And then for the next sort of 5-10 contractions, she was a hell of a lot more comfortable. And there was no more discussion about backache. We were over it. It was done. And it all happened in one swoop, which was fantastic. So the baby must have swung around in one big go. Now that might occur, but otherwise it might be a gradual thing that the baby comes around. Sometimes babies don't. Sometimes babies are in posterior, and they might be full posterior, and they come out that way, and that's okay. Some women are perfectly fine birthing their babies posterior. So please don't see it as some big disaster. Please don't see it as some big drama that we've got to panic over, because it's not. So what we do want to do is work with the baby and enable the baby to rotate around, but if they don't, then they're born, as midwives say, face to pubes, So normally the baby's little face will sweep the perineum as it comes out, but instead it can be the other way around, and the face will come out face to pubes. Now, if you look at diagrams of this, you'll see that the baby's head's shape normally will fit down through the pelvis quite nicely when it's in the anterior position and it rotates its way through, sort of corkscrews its way through the pelvis. If it's posterior, sometimes those babies will come out with a bit of a big forehead. Instead of having moulding at the back of the head, that's one of the ways that we can tell what position this baby was in by how it looks when it comes out. So if they've got a big-ish kind of forehead, now that's not permanent for the rest of their life, that's nothing to worry about. It will correct itself within a couple of days. So it's just the same as that elongated, very moulded head that most babies will have. That's the majority, and you were probably born that way too. And so it's very elongated for the first 24 hours, and then after that it becomes a more rounded sort of head. So it's sort of, the little skull bones go into a more normal shape afterwards. So that's some information about posterior. Now what I would do for a woman who has a posterior presentation, top of my list would be, let's get her in the shower and let's get her feet apart and knees are bent a little bit so she's got a bit of flexibility. She can hold on to the grip rails or put her hands on her partner's shoulders. And then we've got one of the shower outlets. We've got 2 hot taps, 2 cold taps. And you bring one shower outlet down and put it on her lower back, and another one down and you put it on her belly. Now you never bump a woman with these hoses. You always go backwards and forwards from one hip bone to the other hip bone, and you keep it about that far apart from the skin, that far away, and you just want the jet spray on her lower back and on her lower belly. And you do it in a uniform way, backwards and forwards. Now you can be in the shower for 2 hours, 3 hours, and if she's upright and if she's leaning forward a little bit, then that baby may well beautifully rotate around. Now let's just say her legs get a bit tired. We can also use hot packs. Ask the midwife, can we have a couple of hot packs please? Or bring the gel-filled ones that you buy from the chemist. Are you allowed to have hot water bottles in hospital? Are you allowed to have wheat packs in hospital? So the gel-filled packs are what they might have in the hospital. Otherwise you grab them from the chemist, $20. You want them to be about the size of a half A4 page. Okay, so about that size, okay? And you want 4 of them actually. You want one for the belly, one for the back, and then you want to have 2 in the microwave heating up while those 2 are going cold. You don't really want them to go cold. And then as the woman starts to complain, oh, this isn't really working for me anymore, they're not warm enough, right, quick, let's swap those over fast. So we pull them out of the microwave, wrap them up, and then one on the belly, one on the back. And then you can get a big stretchy sarong and tie them in place. Now she could be in the shower, she could be in the bath and have the hot packs as well. Maybe she's sitting on the toilet, and quite a few midwives and doulas say it's a great idea to sit her on the toilet the wrong way around. Grab a pillow, put it over the cistern, probably be flushing the button and be a bit noisy as well, just kidding. And so she's leaning on that, and the angle of all of that will be in a good angle for rotating the baby around as well. Okay, now let's say she wants more help. Well, that's fine, we've got more help. We can do all sorts of things. There's acupressure points. If you go to the back of your doula workbook, you'll see all the acupressure points there. And if we're doing the face-to-face training, and sometimes people are doing home study training and then they go, oh, Julie, I want to have a day with you. And so these would be the sorts of things that I would do for the home study people that want just one full day with me, or if they want to upgrade somehow, then we would run through all of these sort of solutions for posterior, turning a breech baby, all sorts of things. So next level up is I'd be getting her in the bath, of course, knees spread wide, yep, and the hot pack. Now, another level up from that is to do what we call sterile water injections. Now, this has been developed in Australia by a fantastic midwife, Carolyn Hastie, up in the Hunter region, up around Newcastle area. And Caroline had a chat with one of her superiors, her midwifery boss, saying to her, look, here's this kind of unusual thing that I'd like to do for a lady that we've got and she's complaining about, and so I want to do sterile water injections. So I'll just show you on this magnificent yoga lady here. We're talking about this region across here. So this is the lower back, the sacral area, that wide flat area that we've got. So coming down the spine. Now, the idea these days is to have 6 injections of just simply pure sterile water. So the midwives will draw up the sterile water into the syringe, and then they will inject. It's very quick and they're so gentle, and so it's just a quick little slight 2-second sting, and then a little injection and out, another 2-second sting, another 2-second sting, and so that's 6 times, very briefly, very quickly, very gently, straight across that area. Now that's going to create some puffiness in that area, and that will reduce the pain by about 30 to 50%, which is very significant. It can be repeated 3-hourly. So keep that in mind. Now there's no side effects on the baby, unlike gas, morphine, epidural. There's no side effects on the mum other than a quick little 2-second sting 6 times. She can have this done again in 3 hours, and so that's wonderful. It's fantastic as a comfort measure. So we try to use the term comfort measure instead of pain relief. Okay, so it's a comfort measure. It will ease that for her, that backache, and it'll make it a lot easier for her. Many women, when they've got a posterior presentation, they want to walk. Okay, now the rotation of the pelvis helps that baby to rotate around. Some people say walking up and down a set of stairs, which is a bit challenging for a full-term pregnant woman, right, who's in labour, but it could work. Another one is to put one foot up higher than the other so that the pelvis is really tilted. So you could probably get, we used to say a couple of phone books, and they used to be really big, but something that's going to help her, a footstool. Okay, so it doesn't matter whether it's her right foot up or her left foot up, whatever she chooses, intuitively, chances are she's right. So get her to put one foot up and the other foot's down on the floor. She could be leaning on a chair for her stability, or on her partner, or something to just hold on to a little bit, and then moving her pelvis around in circles, or maybe just a swaying motion. Have you heard of dancing for birth? Okay, so it's a special class that everybody can do, whether they're pregnant or whether they're a doula, or whether they're a midwife, and it is awesome. I did it many years ago, about 10 years ago, and the lady running that is just incredible. She's great. So a bit of movement through the body will also help to rotate the baby around. So when women are feeling excessive pain, or when they've got this backache, often they'll freeze up and they'll resist against it, and we don't want that. We want her to loosen up and get moving and move her pelvis around, not in a way that's going to exhaust her, of course, but in a way that's going to help her be more flexible and help to rotate that baby around and encourage her to move in the way that feels intuitively, instinctively comfortable for her as well. Okay, so of course what a lot of women will do if they haven't got a doula, if they don't know any of this information, is just simply go for an epidural. I have backache, I'll have an epidural, which is very unfortunate. It's very high level. Actually, I had a doula come through class last year, and she was doing the in-person study with me, and I got to this part where I was explaining, or beginning to explain about posterior and all of the things that we can do, including sterile water injections. And she said, guess what, Julie, when I was pregnant first time around, I had read quite a bit. I knew about all of this. I was well informed. I went into the hospital. I didn't have a doula, but I went into the hospital, and it was a private hospital west of Sydney. And I said to the midwives, my back is hurting a lot. I'm pretty sure my baby's posterior. What I want you to do, please, is sterile water injections. And the midwives didn't say anything. They walked out. And then immediately in came an anaesthetist. And he said to her, none of the midwives that we have here in this hospital are qualified to give sterile water injections. So I'm here to give you your epidural now. And that was it. So she had the epidural, ended up with a forceps delivery and an episiotomy, etc. And what she said to me in the training was, I'm pretty sure that I would not have ended up with forceps and episiotomy if I hadn't had that epidural. If only they had been qualified. And I said, of course they're qualified. You know, all the midwives in Australia can do sterile water injections, and the training for that is not very extensive at all. It would be, you know, a quick workshop. And certainly they're all qualified to give injections. They're a qualified nurse, and then they're a qualified midwife as well. So there's no way that what he was saying was ethically true. So yeah, anyway, I believe that actually that hospital has closed down. So interesting one, that one, isn't it? So keep this in mind. Posterior often begins with ruptured membranes and no contractions. What we certainly want to do is stimulate contractions. How do you do that? Breast massage, nipple stimulation, reducing adrenaline, boosting up oxytocin, a little bit of movement, and whatever we can do to boost up her oxytocin and reduce any adrenaline, so that the hormone oxytocin will stimulate contractions. Now those contractions, the tightenings of the uterus, will also help to massage the baby around so that the baby rotates and comes out of posterior and goes into anterior. So a lot of babies will eventually correct themselves. So posterior, it's not like a key in a lock. A baby's not jammed in there. There's fluid around the baby. There's the soft muscle of the uterus around the baby. There's slipperiness. The baby's covered in vernix. So does that make sense to you, that babies are really quite slippery and very movable as well? Okay, so if you're interested in doing the training, come along.